Jayasri on Neuro Ophthalmic manifestations of brain metastasis.
Good evening to all. My 7. Ophthalmic introduction. Metastasis to the brain is the most neuroophthalmic manifestations. Secondaries are the most common intracranial tumors in adults. Brain metastases were investigated for primary tumor. It was found that bronchogenic carcinoma 39%, breast cancer 17%, and melanoma 11%. 1,70,000 patients develop brain metastases per year. AIM, analysis of 10 cases with neuro-ophthalmic manifestation due to brain metastasis who presented to our neuro-ophthalmology department in a tertiary eye care center. Out of 10 patients, 8 patients were known cancer patients on treatment. In 2 patients, neuro-ophthalmic manifestation was the initial presentation which led to the diagnosis of primary tumor. The presenting complaints vary defective, they present as the defective vision, diplopia, or headache. For all patients, detailed neuro-ophthalmic examination was done, visual acuity, color vision, central fields, neurological examination including cranial nerves examination, anterior segment, pupil and fundus examination, diplopia and head starting if required, and systemic examination and neuroimaging wherever required. Neuro-ophthalmic manifestations of brain metastasis due to bronchogenic carcinoma. Out of 10 cases, we had 4 bronchogenic carcinoma. Out of 4, 1 case, they present initially with neuro-ophthalmic manifestation. Then we find out the metastasis with the primary tumor together. Case 1, they present with the complaints of defective vision, 6 months duration with best corrected visual acuity, PL both eye. So on examination, they manifest as secondary optic atrophy. In case 2, they present with diplopia. So on examination, they presented as manifested as a right multiple cranial nerve palsy. Case 3, they present as a sudden diminution of vision, 10 days duration with best corrected visual acuity of hand movements both eye. On examination, they manifest as fundus as a chronic papilledema. The 4th case, which present as an acute 6 nerve palsy, so we ordered neuroimaging, then we find out the brain secondaries as well as the site for primary tumor. So it's contrast enhanced imaging which shows the temporo-occipital metastasis which cause the chronic papillary edema, and cerebral metastasis with edema with midline shift which cause the secondary optic atrophy, and the metastasis involving the clivus and sphenoidal sinuses which cause the 6th nerve palsy. Then coming to the neuro-ophthalmic manifestations of brain metastasis due to the breast cancer, out of 10 cases, 3 cases we had breast cancer on treatment. So case 4, they present with sudden diminution of vision since 7 days. So on examination, we saw the normal fundus and diagnosed as retrobulbar neuritis. And case 5, their complaints present with diplopia since 15 days. They on examination, they manifest as left multiple cranial nerve palsies. And case 6, they complaints of headache and pain since 2 weeks. On examination, the fundus shows established papilledema. So contrast enhanced imaging which shows leptomeningeal carcinomatosis of cerebellum with hydrocephalus which cause retrobulbar neuritis, and cerebral and brainstem metastasis which cause the multiple cranial nerve palsies, and cerebellar metastasis with hydrocephalus which cause chronic papilledema. Brain metastasis due to chronic myeloid leukemia. The patient present with complaints of diplopia 1 week duration. On examination, it manifests as right 6 nerve palsy. So on neuroimaging, which shows the leukemic deposits involving the right cavernous sinus. Brain metastasis due to hepatocellular carcinoma. It presented as a diplopia 4 days duration. On examination, it manifests as left 6 nerve palsy. So we ordered neuroimaging. The neuroimaging which shows the clival metastasis which caused the 6 nerve palsy. Then brain metastasis due to thyroid malignancy. The 42 years old female patients came with complaints of headache since 20 days duration with best corrected visual acuity was 6/6 both eye, no history of systemic illness. So on examination, the fundus shows established papilledema. So we ordered neuroimaging, the CT brain which shows the multiple cerebral metastasis with compression of ventricles. So this case we find initially they manifest as a neuro-ophthalmic manifestation of manifestation without known cancer. So we diagnose the brain metastasis along with the primary tumor. tumor together. That is synchronous presentation. So coming to the discussion, metastasis to the brain is the most feared complications of systemic cancer. It may present with various neuro-ophthalmic manifestations depending upon the site of metastasis. Secondaries are the most common intracranial tumor in adults. Cerebral metastasis occurs in 15% of patients with cancer. In 15% of patients, primary remains unknown. In order of decreasing frequency, lung, breast, melanoma, renal, colon cancer are the most common primary tumors metastasis to the brain. Metastatic brain tumor spread by hematogenous spread to the skull bone, from where it spread to the suprachiasmatic space brain, or it directly metastasis to the brain. The location of the metastasis depends about the blood flow to that area. Cerebral hemisphere 80%, cerebellum 15%, brainstem 5%. The most commonly involved gray-white junction. The primary site, first one is the lung carcinoma, then second one is the breast cancer, the second most common cause of brain metastasis. The best diagnostic test for brain metastasis is the contrast enhanced MRI. So for according to the site of the neuro-ophthalmic metastasis, it presents with various neuro-ophthalmic manifestations as optic neuritis, papilledema, optic atrophy, and no palsy. The treatment metastatic depends upon the tumor's nature and extent of the primary process, nature and severity of the neurological and visual symptoms. To conclude, brain metastasis should be considered in any patients with ocular symptoms in the absence of intraocular cause, particularly in case of systemic cancer patient. Neuro-ophthalmic to find out the primary tumor, although the treatment is frequently aimed to reduce the symptoms and extend the survival. Thank you.
Thank you.
Thank you, Doctor. Can you diagnose the ocular symptom before the primary?
So
in any of the cases,
yes, sir,
you suspected that there is somewhere else is the metastasis, and you refer the patient.
But we had two cases, sir. Two cases. Patients, we first rule out the systemic illness. So then we order neuroimaging, find out the metastasis, sir. The another
primary one was already diagnosed earlier.
No, already diagnosed in 8 patients, primary, known cancer patients. But 2 cases, they initially present with neuro-ophthalmic manifestations. We only diagnose the primary site. By neuroimaging, they search for primary site and diagnose the primary tumor.
Okay, thank you.
Yes, my number is 267.
Okay, thank you.
Thank you, sir.
Yes, yes.
Have you done CSF analysis in these cases?
So, no, sir. We confirm the diagnosis with neuroimaging itself. Metastasis itself is causing papilledema and everything. So, first we refer all the cases to the oncologist. They themselves start anti-edema measures. They gave steroids and IV mannitol. They control, and then the whole brain irradiation they gave, sir. So no need of CSF analysis, I think so.